What I just quickly want to say before you guys get started. So the reason why and first of all, Pete's IR in general plays a big role in East Africa, given that we're dealing with a median age of somewhere between 16 and 17 years. And we do see a lot of pediatric patients. But then recently, I mean, there've just been a lot of requests for pediatric nephrostomy placements. And, while a lot of them certainly are indicated, some of them may or may not be. In particular, the question came up with like posterior urethral valves, etc. So we just figured that it's very important. I mean, we obviously always try to teach our trainees it's not just about what procedures you can do, but most importantly, you need to know what to do and when to do it, and in particular when not to do it. So that's why we reached out to Jay and asked him if he could give a presentation, and then he suggested to also invite you from the urologic side, which is a great idea. So we're really looking forward to this, and this is very, very important topic for the trainees in East Africa. So thank you so much.
Absolutely. Well, thank you very much for having me. Thank you to Jay for including me on this in this program for today. Um, so, in terms of the top for today, pediatric genitourinary interventions, and so just a brief outline. So we'll start off talking about general kind of congenital hydronephrosis, briefly on the prenatal, mostly on the postnatal evaluation, and then overview of different areas of genitourinary obstruction. We'll start off with kind of overview of the standard management, and then I've included some slides too that are in green that are specific to interventional radiology in terms of when we would ask for their help for in the normal kind of standard of care. So this is the busy slide, but it is a kind of overview and kind of the foundation for what we'll be talking about in congenital hydronephrosis. So after baby is born, usually it's a diagnosis of prenatal hydronephrosis here in the States, but after baby is born, we obtain an ultrasound. Um, let's see. That's usually obtained 24 to 48 hours after birth. And the reason why we wait, it's not done within the first few hours, is because dehydration can cause a false negative. You have decreased urine production, and it may show a decompressed system, even in the context of an obstruction. And so when we look at the ultrasound, specifically as urologists, we're looking at the length of each kidney relative to each other, the renal pelvic diameter, which is measured in the transverse window, and the echogenicity of the renal parenchyma. And so we grade this very kind of rudimentary, grade 1, grade 2, grade 3, and grade 4. And we make our main dividing line between grades 1 and grade 2. Grade 3 and grade 4, we kind of consider more high-grade hydronephrosis typically. That's where you have dilation of the minor calyces, but preservation of the renal parenchyma. And then grade 4 is all of the above, but with thinning of that renal parenchyma. So typically for SFU grades 1 and 2, we don't really worry about that too much. That has a high likelihood of spontaneous resolution. And for those, depending on if it's grade 1 or grade 2, we just repeat the renal bladder ultrasound within 1 to 3 months, and then go from there. Now, typically in our practice, most of us providers, we repeat the ultrasound 6 to 12 months if that's normal, up until the patient is toilet trained. And the reason why we wait until that time is because it's a good milestone where the child is able to tell you, hey, I'm hurting on my one side or the other. Oh, I've got blood in the urine. Oh, I've noticed some other symptom. And so if you see them through that milestone, then our thought is if you see them through that milestone, then you kind of cover the early stages in life when they really can't speak for themselves. Now, on those ultrasounds why we do serial ultrasounds, if we see worsening hydronephrosis, or they develop a urinary tract infection, they get additional workup for that hydronephrosis. So then looking more kind of towards the focus of our conversation today, we look at higher grades of hydronephrosis. And typically, when I see a patient in clinic with grade 3 or grade hydronephrosis, whether it's unilateral or bilateral, they get a MAG3 scan, which is a nuclear medicine diuretic renal scan. They get a VCUG, and those are kind of the two mainstays. Here in the States, in Atlanta specifically, we're lucky to have MRI urography, which is a specialized MRI scan that has measures renal function. But it's more specific to Atlanta in the United States than most places across the country. But our standard is MAG3 VCUG for high-grade hydronephrosis, grades 3 and 4. So MAG3 nuclear medicine diuretic scan, we inject contrast the nuclear medicine agent through an IV. We usually obtain this 3 to 4 weeks after birth, just to allow time for the kidney to develop. And the most important thing, what I tell parents, that it evaluates both function and drainage. And the typical discussion with the parents is I kind of equate it to 2 light bulbs that are in a room. And so the first, when you turn on the switch, that is the nephrogenic phase that tells you the function of each kidney relative to each other, the differential renal function. And the next part of the study is you turn the light switch off, and that's the equivalent of giving Lasix, and you see how quickly the light dims. And so if the T1/2 is 0 to 10 minutes, we consider it normal, or greater than 20 minutes, we consider it more obstructed, okay? So we look at the T1/2, the differential renal function. Some of us will look at the percent washout too, and we also look closely at the slope of the drainage curve. VCUG, we really can obtain anytime after birth. Here we use a feeding tube, and then we do a cyclic VCUG. That way we get the more consistent results over during that study. On the report, we're specifically looking at bladder capacity, how much contrast do they instill, if there's reflux present, and that's vesicoureteral reflux. So we grade it on the typical grades 1 through 5. Now we also look at the time of the reflux. Does it happen early on in the fill cycle, middle of the fill cycle, late in the fill cycle, or during the voiding phase? In the voiding phase, especially for our discussion today, that's going to be the most important phase, because that evaluates the posterior urethra in males. So when we look at the VCUG, kind of going more to focus of the conversation, posterior urethral valves or bladder outlet obstruction. So posterior urethral it's a congenital form of bladder outlet obstruction. It only occurs in males. It's where you have small little membranes or leaflets of tissue that cause an anatomical obstruction to the flow of urine, and that's distal past the vera montana. Okay. The postnatal diagnosis of valves in certain sizes comprises 40 to 60% of all PVU patients, but a lot of times we see this prenatally. In our we get a hint of this prenatally as if we have bilateral hydroureteronephrosis, we have a distended bladder during prenatal ultrasounds, and especially if there's oligohydramnios. And a considerable amount of patients, 20 to 50%, will lead to end-stage renal disease. So this is some of the epidemiology, which we'll kind of gloss over, but this is the classification of valves briefly. So just in context, we have the bladder right here, the bladder neck right here, and these are the valve tissues right there, okay? So you can see this little hump right there is the vera montanum, and it's distal to that. So pathophysiology of fetal urinary tract obstruction. So we'll briefly kind of go over this. But when we have severe cases of valves, we have oligohydramnios, and if you have oligohydramnios, you have pulmonary hypoplasia. And so some of these kids with a severe situation for posterior urethral valves, they have severe other organ systems involved. They cause back pressure and retention of urine and high pressure on the developing urinary tract. And we've talked about the evolution of the valve bladder itself. So the reason why valves plays such a big important role in urology is it affects both the bladder and then both kidneys as well. So with the valve bladder, you're obviously not able to empty completely, and that you have the elevated PVR, which causes stretch, collagen deposition, which causes morphologic changes along the bladder wall. That can cause reflux and increased pressure to the kidneys, And then because the kidneys are progressively damaged over the course of development embryologically and after birth, you have concentrating defects. So then you develop polyuria. Then you have more urine production. Less urine gets evacuated out of the bladder, and you have a continuous cycle of collagen deposition, elevated PVRs, and progressive kidney damage. And that's what we term the valve bladder. On the upper tract, you have obviously increased pressure back to the kidneys, causing hydroureteral nephrosis and defects in the different parts of the kidney, the medulla, and you'll have the loss of the concentration gradient. So in terms of the valves, this is a case of, I got it from the AUA core curriculum, the American Urologic core curriculum, where you have a distended bladder right here, and then dilated posterior urethra right here. You have severe dilated and tortuous reflux on this side, and you also have the presence of multiple diverticuli in the bladder. But this dilated posterior urethra is pathognomonic posterior urethral valves. This is a image of a fetal MRI, which is not standard here, but on specific cases from the maternal fetal medicine doctors, we obtain a fetal MRI, and you can see a specific keyhole sign where you have dilated bladder and a dilated posterior urethra that kind of looks like the configuration of a keyhole. Postnatally, the first thing that we do is stabilize the patient. So usually they are admitted to the neonatal ICU. And from a urology standpoint, the very first thing that we do is we place a Foley catheter for decompression. Now, the Foley catheter placement can be somewhat difficult in these kids because you have development of a posterior urethra that's dilated, and it can cause a high bladder neck. So typically, whenever we place the Foley catheter, which is usually just a 5 French feeding tube, we get a ultrasound afterwards to confirm good placement of the tip within the bladder. They always get an obviously a renal bladder ultrasound that we had talked about. And if you have a baby boy with bilateral severe hydronephrosis or hydroureteral nephrosis and a history of oligohydramnios, it's basically posterior urethral valves or some other bladder outlet obstruction until proven otherwise. So we don't let them go home. And once stable and the catheter's in place and they're good from their other organ systems, most specifically the lungs, they get a VCUG, which is the gold standard for diagnosis. Our practice at Children's Healthcare of Atlanta is to place a 5 or 6 French catheter. We maintain that for a week while the NICU doctors, the neonatal ICU doctors kind of optimize their other organ systems. And after 1 week, we upsize it to an 8 French catheter. And the reason why we upsize it to an 8 French catheter is it allows us to place a neonatal resectoscope in there to ablate the valves, okay? With these catheter placements, sometimes we use catheters that have balloons at the tip of them. However, we never inflate the balloon. And the reason is you inflate the balloon in such a abnormal and small contracted bladder that the balloon can actually cause bilateral ureteral obstruction. And that's happened to me one time when we deflated the balloon and the kid convalesced afterwards. So this is a quick video of just a valve ablation. I know most of the audience is interventional radiology, so this is just kind of how we typically do this. And I got this from the AUA core curriculum again. It's just a quick little video. You can see right here, that's the vena montanum. They're entering into a bladder right here. And then there's a vena montanum right there. And then you can see these valve tissues right there that it's cut with a hot knife or a cold knife, depending on resources available. I typically use a hot knife, but a cold knife works just fine. And so you basically ablate these valve tissues right here at 5 o'clock, 7 o'clock, and I also do a 12 o'clock incision too. One way that I usually do this when I'm in the operating room is I fill up the initial bladder that's in there, fill up the bladder, and then before I do any resection, remove the catheter, get an assessment of the urine flow by doing a little Credé maneuver where we press a little bit of pressure on the bladder and see the urine flow. And then I repeat that same exact maneuver after I do the valve ablation to see the improvement in the urine flow. And it's pretty dramatic. So the timing is somewhat of a debate. As long as the newborn is stable for the OR, we do it. And as long as we know we can get a resectoscope in, which that's why we upsized to 8 French. We leave a catheter in 24 hours after ablation, and just to allow for a little bit of hemostasis. But that's a typical resectoscope look right there. And these are more kind of representative pictures of valves. So here's the green slide for IR interventions in valve cases. These are kind of possible scenarios that have occurred to me and we've encountered. So if the initial catheter cannot be placed, so a baby is born, they have bilateral hydroureteral nephrosis, we're concerned about valves, we have a high clinical suspicion. The urology team or the DERT is unable to place the catheter per urethra, but they're not able to. So at that point, we need to divert the urine. And so the preferred method would be to place a suprapubic tube to allow decompression of the bladder that way. Okay. And that can be done ultrasound guided, probably the easiest way to do that. Another scenario is, say we're able to place the catheter. We haven't gotten the VCUG yet, but and the catheter's in good position. So we've confirmed that on ultrasound, the tip of the catheter's in the bladder. It's a decompressed bladder, but for some reason the hydronephrosis is worsening, or we have worsening kidney failure. And we actually had a case of this upstairs now, kids in the ICU with this exact scenario. The catheter was well in the bladder, but he had worsening hydronephrosis, worsening kidney failure, and his clinical situation was worsening. Now, we hadn't had that diagnosis of valves yet because he wasn't stable enough to get the VCUG, but my presumption was that the bladder wall thickening was causing a distal ureteral obstruction and causing upper tract obstruction. And so he ended up getting bilateral percutaneous nephrostomy tubes, and he's now slowly improving. But without that IR intervention, he would be clinically deteriorated by now. The another situations for IR intervention in valves cases is urinary ascites. And so the pathophysiology with valves and urinary ascites is that the bladder is obstructed below the level of the bladder, or below the level of the bladder in the posterior urethra. And you have dilation of the bladder in both kidneys. And what that can cause is something called a calyceal rupture. And that calyceal rupture then leads to urine outflow because the urine will take the path of least resistance into the retroperitoneum, and then it causes a transudate into the abdominal cavity for urinary ascites. And so IR is involved to place a peritoneal drain to test that for urine and creatinine, and that's how they're diagnosed with urinary ascites. Very rarely do you see a bladder rupture from valves, but that is always a possibility. And it's usually in the context of kind of aggressive initial catheter placement in that thin neonatal bladder. Sometimes you can perforate that and then you can cause urinary ascites, in which case they would need a drain placement at that time. So that's kind of the discussion on valves. Now, another point of obstruction is uretropelvic or uretrovesical obstructions. So ureteral obstructions, essentially. And briefly going over these, we classify these into two major categories: intrinsic, which is just a congenital narrowing, or extrinsic, which is usually due to a lower pole crossing vessel. Okay, and so what happens is you have an accessory lower pole crossing vessel that then causes a kink at the level of the UPJ, and usually they're compensated at the time of birth, but over the course of the first few years of life, or even first few decades, because we see this in adults too, that kink becomes so severe and the hydronephrosis in the renal pelvis becomes so severe that it flips over the vessels and causes obstruction. And usually that is the clinical symptoms for that is severe episodic pain. Okay. Now, if you have a UPJ obstruction, you obviously can have decreased unilateral kidney function, pain, you're at risk for higher infection and pyelonephritis, and then you have a risk for developing hypertension later on. In our standard management, the evaluation is to get a MAG3 scan that we had talked about, or here sometimes we get an MRU, which we use for more complicated anatomy. Again, we're looking at the differential renal function, the T1/2, the drainage curves, and we look at their clinical symptoms. So if they're having episodic pain, 30 minutes over the course of many months associated with nausea and vomiting, and they have this type of ultrasound and this type of MAG3, then that's a surgical indication to do a pyeloplasty. And so We typically do this in infants open through a small flank incision. It's about 3 centimeters off the tip of the 12th rib. We're able to identify the renal pelvis and the area of obstruction, and this is called an Anderson-Hines dismembered pyeloplasty, where we remove the affected segment and then using absorbable suture regular ureter back to the pelvis. And then we typically leave a ureteral stent in about 3 to 6 weeks, depending on provider preference, and then we remove that with a second surgery. For a UVJ obstruction, that's where you have a distal obstruction close to the level of the bladder. The typical management for that is a ureteral reimplant, and we do that either open, laparoscopic, or robotic. And depending on the degree of dilation in the ureter, which is usually what we call a mega ureter, we have to taper, which means kind of fold the ureter onto itself to decrease the amount that we have to place into the bladder, or we just excise longitudinally extra ureter and tunnel that into the bladder. So IR interventions in kind of more upper tract obstruction, so above the level of the bladder. So absolute indications, if the kid has a solitary kidney and they have an obstruction on that solitary kidney, then an IR nephrostomy tube is placed to allow for decompression until we can do definitive surgery. Similarly, if there's an infection, we place an IR nephrostomy tube for decompression. And the benefit for this is sometimes it's very obvious where the obstruction is. Is it in the UPJ or UVJ? But a lot of times there can be a ureteral stricture due to some other reason, maybe malignancy or previous surgeries or previous stones. And so a nephrostomy tube allows you to do an antegrade fluoroscopy study to further define the obstruction, so we can pinpoint exactly where the obstruction is. Lastly, if a kid comes in with severe pain, has a known UPJ obstruction, sometimes we use a nephrostomy tube as a temporizing measure until definitive surgery. And it's surprising. Their pain is so severe that they'll rather take the nephrostomy tube rather than deal with the pain. And so we don't leave the nephrostomy tube for very long. We get them scheduled usually within the next week or so to get this taken care of. And obviously, similar in the situation for solitary kidneys, bilateral obstruction, where you have both kidneys affected by some sort of obstruction, you do that. So in conclusion, this is kind of brief overview. Most hydronephrosis resolves spontaneously. So the vast majority of kids come with grades 1 or 2 hydronephrosis, and there's really no need for intervention for all cases of hydronephrosis. The ones that we work up more thoroughly are grades 3 and 4, what we call high-grade hydronephrosis, or lower grades of hydronephrosis that then have urinary tract infections or worsening hydronephrosis. The gold standard is, working up properly with either a drainage scan or with a drainage scan and a VCUG. And we typically use IR interventions as a temporizing measure to stabilize the patient, but also to help study the anatomy so we can, when we do the definitive surgery, we have a clear understanding of what the anatomy looks like. That's all. I would love to open it up with questions, and thank you again for letting me present.
Thanks, Shuvro. Yeah, I thought that was a really great lecture, and I learned a lot too, actually. And I know we worked together.
Now there's a bit of an echo. I think you'll have to.
Let me turn.
I muted mine.
Here. Why don't you turn yours on? I'll turn this one on.
Okay. I'll just leave this meeting and we'll choose yours.
Okay. All right. I think this is better, maybe.
Yeah.
Perfect.
All right. Yeah. So any questions from the audience, just sort of from that really comprehensive overview of how hydronephrosis should be managed?
Alex, Eva, I know that you guys have had a bunch of those even just recently. Did this clarify things, or are there any particular cases that you can remember that you've seen recently where you weren't sure?
Yeah, so thank you so much.
think-
It was very, very helpful. I think Dr. Bugeza has a question. I'll let him speak for himself.
Thank you, Eva. I was just asking about leakage. I think you didn't talk about leakage. If there's leakage, maybe ureteric, would there be an indication to do a nephrostomy? Otherwise, I think we are very grateful. Recently, we are kind of stuck when we are told that there's no chance of doing nephrostomies in infants and babies, and we are wondering what to do. But this presentation has really been very helpful. Thank you.
When you say leakage, what do you mean? Do you mean just like continence, or am I misinterpreting?
Like other indications in nephrostomy is leakage. If you have a urinary leakage, maybe trauma, and you
Oh,
have
yeah,
to.
yeah.
Yeah. So if in that situation, say there was a trauma where you do have like a ureteral transection. Here we see it with gunshot wounds or other car vehicle accidents too. Um, if there's evidence of renal kidney trauma and damage to the collecting system, then some sort of intervention, whether it be a nephrostomy tube or a ureteral stent, would be indicated. So some way to decompress that renal pelvis and prevent leakage from happening, divert the urine away. The key message is diversion if we don't understand what's going on. And so if it's yeah.
Great question. Let's see okay, so there's a question about the role of a Whitaker test and what to do in the absence of MAG3 and
A VCG.
VCG.
Yeah. So typically, our standard is to order a MAG3 and a VCG. Our main thing is that for an infant with bilateral hydronephrosis, we have to get a VCUG to rule out valves, especially if in high grade hydronephrosis. So if the clinical suspicion is high, there's lung issues, not making great urine, the urinary stream is dribbly, oligohydramnios. These all point to a diagnosis of valves. And so we typically get a VCUG. And if we're not able to get a VCUG, then a catheter is the first line.
And I'll make this argument, and I know this is sort of just thinking outside the box, but in this sort of forum, we have a lot of interventional radiologists who have access to a fluoro suite. Obviously, I'm sort of double trained pediatric radiology and pediatric interventional radiology, or adult interventional radiology, and I think a VCUG is actually something that we can do on our fluoro machines. So that's just food for thought, that if we do want to go down this route and expand these service lines in, Uganda and in Tanzania, we may just have to take the onus on us until we get proper pediatric radiology to maybe perform the VCUGs. Because even, to be honest, here at CHOA, sometimes the diagnostic radiologist doesn't feel comfortable placing the Foleys, and I have to place them, and things like that. And so we may, especially if it's of interest and we want to come up with a protocol, we may just have to come up with doing VCUGs in IR before placement of the tubes, and that might be helpful, especially to rule out the 1s and 2s.
Yeah, the grades 1s and 2s, honestly, we just kind of get ultrasounds on, but if there's a clinical suspicion that's high enough, then we would get the VCG, yeah.
So I think that's probably a really big takeaway point, is just making sure that the ultrasounds are read properly and the 1s and 2s are identified properly, because we are probably over putting in hydronephrosis interventions if that is the case. Let's see, role of Whitaker test. So
yeah, so the Whitaker test is as a background, it's kind of historic test, but not a bad test actually if you don't have a MAG3. And so it's basically, Whitaker test is you compare the pressure differential between the renal pelvis and the bladder. And if there's a significant high enough pressure differential, then you would assume that there's an obstruction present. And so if there's no MAG3 available or no drainage scan available, then a Whitaker test would be indicated, especially if you have an ultrasound that's concerning for obstruction. So I would say, grade 3 or 4 if you don't have a MAG3 and all you have is, you know, a pressure transducing catheter where you can measure the pressure, then that would be a workup for it. That could replace the MAG3 if we didn't have it.
What about distended bladder and bilateral hydronephrosis is detected during a pregnancy? Do you still wait for delivery or intervene during the pregnancy?
So that's a good question. So we didn't talk about antenatal or prenatal interventions here. That's very kind of controversial here in the States, just because of the high rates of preterm delivery due to prenatal interventions. The key things that we look at here, if there's bilateral hydronephrosis detected during pregnancy, the major determinant of outcome, at least in the initial postnatal period, is going to be whether the presence of oligohydramnios. So if there's oligo or definitely anhydramnios, then depending on how many weeks we are with the baby, we would probably deliver early. So if we're kind of after 33 weeks or so, and there's oligohydramnia starting to develop, the maternal fetal medicine doctors will want to deliver sooner rather than later.
And you're talking fetus or mother?
What do you mean?
Like, I think they're talking hydronephrosis of the mother.
No, hydronephrosis of the fetus.
Yeah, but I
Yeah.
think he's asking.
No, I think they're asking fetus because this actually came up just a few weeks ago in Uganda, if I remember
Oh,
correctly.
fetus. Okay, sorry.
Yeah, no, they were asking for it.
Got it.
Mm.
So yeah, so then delivering early is
So
indicated.
sometimes, and that would be in only severe cases. Now, that's I think happened to me in my practice maybe 1 or 2 times, but most of the times, the risk of prematurity and subsequent NICU stay is significantly high. That we would wait till baby becomes term or closer towards 37 weeks, as close we can get safely, and then deliver at that point. But that's usually a decision not so much for pediatric urologists, it's more for the maternal fetal medicine doctors.
Awesome. Is there a role of putting pigtail catheter in if those parameters are not met?
Pigtail catheter, you mean in the fetus?
Like
Prenatally?
Prenatally. I think the risks are probably gonna outweigh the
Yeah, so it's prenatal, yeah. So that's that we call it a vesicoamniotic shunt. And that's the one that's associated with a lot of premature delivery and potential complications. And so there's certain specialized centers in the United States that do it, and we are not one of them. But so that's the prenatal intervention. We don't do this in Atlanta. And I think there's only a handful. Yeah, Texas and maybe Philadelphia do it. But it's very specialized in terms of
and you should only do it if you're somewhere where you're comfortable delivering the baby at that stage.
yeah. So at 20 weeks or so, if you notice this, it would not be a correct indication to do that.
All right, it looks like the questions are slowing down. So I put together a couple slides just about nephrostomy tube placement, and I just put 2 cases together. I think it is probably a repeat of what everybody knows, but I figured I'd throw these up there. So I can put those up.
Please do. Please do. I mean, those are such common cases that, the more everyone hears it, the better.
Yeah, so let's do. Zoom meeting. All right, can everybody hear and see?
Yes, we can.
All right, perfect. So, so this is sort of the first slide, and you know, I don't really care what drain anybody uses. This is generally the pieces that come in the kit. So the first one is the trocar stylet, and if you're doing Seldinger technique, this is something that we always throw away. The next one is the rigid cannula, and then there's the flexible, that plastic cannula, and then the drain itself. Um, for cases of pediatric hydronephrosis for really little babies, NICU babies, low kilo babies, I have found that actually, although Seldinger technique is all we teach you guys and basically talk about how safe it is, that the trocar technique actually works a little bit better. And that's because the retroperitoneum of these babies is so soft that when you stick with the needle and then you end up putting a thick 035 wire in or like an Amplatz wire or something, it actually pushes away the kidney. And then sometimes you can't tee off the drain. So this is a kid with significant, this was the one from this weekend.
Okay.
So this is a kid with significant hydronephrosis. I mean, you can see sort of basically very thinned parenchyma. And what I did was I took a 6 French drain, I left the trocar in it, and then similar to how you would use a UE needle or a big Chiba needle, I basically made a big lidocaine wheel and then incision, and then under ultrasound guidance, put the entire trocar in and then teed off the pigtail. And that's sort of a technique that I use with these smaller babies that is maybe like an advanced technique or a technique that people will feel less comfortable doing. But it's sort of what I tell our fellows here is that you sometimes have one shot because if you try with the Chiba and you decompress the kidney, you sort of don't have another shot. And if you push with the Amplatz and you sort of shred the soft tissue in the peritoneum or the retroperitoneum, it kind of gives you these false tracks that then it's hard to get out of. And so this 6 French trocar technique is something that I sort of have fallen back on, especially for the little babies. And then once you place the drain in, you tee it off like you would off of a wire, and then you can use fluoro for the rest of the case. And this is what.
Quick question, Jay. Like,
Yeah.
you know, six French drain, like ballpark until like what age or weight or whatever do you use 6 French, and then when do you go to something larger?
Yeah, so the smallest drains that we carry are 5 Frenches. I would say that probably the first week or two of life we use 5 French drains. I would feel comfortable using a 6 French drain almost till 6 months of life. I would say 3, 4, 5 kilos. After that, you can generally get away with a larger drain. I will say that if I'm gonna do trocar technique, I usually will use a 6 French drain. If I'm gonna use Seldinger technique, then I'll move up to an 8 French drain, and that's only because, and this is something that you'll have to learn sort of with experience, is that when you do the exchanges for Seldinger technique with the 6 French drain, because of how small the drain is, how tight the taper is, and the materials of the drain and the Amplatz, sometimes the wire won't come out of the drain when you put the drain in, and then you end up having to pull everything. So I think from a kilo baby size, I would say first 6 months of life, think about 6 French. If it's a very small baby or a difficult baby and you're going to trocar it, 6 French. If it's a larger baby, I would say use an 8 French. Like if you're going to use Seldinger or do an exchange, use an 8 French or use a set of drains and wires that you have had good luck exchanging with. Because for me, especially here with the equipment that we have on the shelf, our 6 French often gets stuck on the Amplatz and both get pulled out together.
Got it. Thank you. No, that's great because we got like several hundred 6 French drains donated by Boston Scientific, and you know, I was like, oh, what are we gonna use those for? But this is like a great
Yeah,
use
this
case.
is
And
the perfect use case for it. Yeah, exactly. So this was just sort of a Seldinger technique. So this was our Chiba needle that went in. This is a little bit older kid, a teenager. And there's a little bonus on this case because there was a metal double J stent that urology had placed, and it was unable, it was actually not doing much. The patient still had hydronephrosis. And so we got asked to remove this stent and then place our own hydronephrosis drain. So here we stick with, and kids are skinny. You can use a micropuncture, you can use a Chiba, you can use one of the many kits. I have them listed at the end, the AccuSticks, the Neff, the Greb, all those things. But basically stick with a small needle under ultrasound guidance, fill the calyces, then place the small wire for distal purchase so that you can get your sheath in. Here, once we got our sheath in, we then put another wire down the ureter because we were going to snare out the stent. You can use this technique in a complicated urology cases as a safety wire so that when you're kind of messing around or trying to get PCNU access, as if you accidentally pull out the sheath, at least you have a wire in the calyx still. So, and the AccuStick set actually advertises around that you can get 2 wires in. But anyways, so this one we put the 035 wire down the ureter. We then put the casing down and opened up basically this tulip end snare. We caught the end of the loop, snared it out of the kidney so that we could then place our own thing. This is just kind of
what kind of lecture is this? The IR lecture?
so this was just the warning that I give people is make sure that you use a sheath big enough that's 2 times the size of your object that you're snaring, because if it folds in half and you're pulling it out, you're going to lose your sheath. And then off of our safety wire, we upsize that to an 035 drain, and then we put that the regular enough tube in. And this was an 8 French drain, and I think this was a 12-year-old or an 11-year-old. So just like Fabian was alluding to, I know that we have sort of lots of different kits from lots of different donations at all the different sites. I think the micropuncture kit, I actually just like using the simple micropuncture in babies. The needle is sharp, babies are small. It's sort of easy to use that. And so if you're not going to do a trocar type access, the micropuncture with that 018 wire works really well. And then the 5 French drain, actually, depending on which kit you have, make sure you table test it. But there are 5 French drains that actually have a decent non-step off of that 018 wire. Otherwise, there's a Jeff set, a Greb set, the Neff set, the AccuStick set. There's a bunch of them out there. They all essentially are the same. They all come out with these various coaxial kits, but the AccuStick, for example, they advertise that you can do an 038 next to an 018, so you can keep a safety guide wire. Some of them will advertise that their needle is easier to see under ultrasound. I don't really stick to brands. I don't really care. Whatever they drop is what I use, but just be aware of what comes in your set and if it's triaxial or coaxial or what all the different pieces are. Just the same way, there's a million types of drains. There's the Uracell, the Skater, the Cook, the Boston Scientific. Again, I generally think all the drains are fine. I don't really care. I use Skaters more than anything, mostly because that's just what we have on the shelf here. We have Uracells also. Just beware with these, and this is just something with table testing and kind of experience, is that some of these, because of the taper at the very end, it'll catch on a braided wire. So if you're using an Amplatz, which is probably what a lot of you guys are using, make sure that the drain easily gets on and off the Amplatz, because otherwise you'll get access. You'll put the drain over the wire, and then when you try to pull the wire out, it'll pull out everything. And so that's just sort of a word of warning. And so those were just a handful of urology cases that we helped intervene in with my partner Shuvro here.
Yeah, and we didn't talk about kidney stones too, but the same principles apply for IR interventions, especially with kidney stones. You have a large stone greater than 1.5 centimeters, and the urologist wants to do kind of percutaneous nephrostomy, or if the kid comes in with an infection and an obstructed stone, you know, we try to do a ureteral stent, but if the stone is large, and we know we're going to have to do a percutaneous surgery, and go through the back, then a nephrostomy tube would be indicated there.
I have a question about not using an 035 wire because it gets stuck in a 6 French cannula. Isn't using a 025 wire an option in that case?
Using a what type of wire? Sorry.
025.
Oh, 025.
A 025, yeah.
Yeah.
Still perform that Seldinger technique.
Yeah, so you can use an 025 wire. The thing that I'll just make sure is when you test it on the table and just make sure that the step off of the end of the wire the end of the drain isn't too much of a step off of the wire. Because sometimes if there's a catch and it's not tapered well enough, it'll make it difficult to push. If you dilate, then generally the 025 wire works fine, especially with the 5 French drain. I've been able to get away with the 018 or the 025 wire as well. But with Seldinger technique, remember that you have to play this sort of balance between the stiffness of the wire to be able to stably get your drain in, but also not too stiff to push away the kidney or to shear the parenchyma.
Yeah. Thanks.
And remember on these NICU babies and kind of these babies with congenital hydronephrosis, oftentimes if it's like a UPJ, no matter how hard you try, it'll be hard to get down into the bladder because there's like an obstruction or a band there. So like, we work hard to get down into the bladder for these adult ones, and I always encourage that the more distal purchase, the better. But in these very little babies, it's sometimes difficult to do so. So you're working from the bottom calyx to the top calyx is how much purchase you have. And so that's why sometimes the trocar technique kind of helps.
And too, that's kind of a discussion too between the urologist and the in the IR interventionalist. For that case that Jay showed, it was my patient. We didn't have to get ureteral access down into the bladder because we're eventually going to do that pyeloplasty when she gets free from the infection. So all we need is just the nephrostomy tube, and actually doing the PCNU and trying to get access all the way down makes the eventual surgery more difficult because it causes more inflammation and more trauma.
Yeah. Yeah, so I totally agree with that. We make phone calls all the time to each other while we're doing cases because of just the nuances of the surgeries. And I didn't realize this until I was an attending, was that there was some times where I just thought, okay, you know what? It's going to be better to get a PCNU and I want to show off. And then I call Shuvro and he's like, no, dude, don't do that. It'll make my job way harder. So please just put in the simple PCN. Samuel Bugeza. Okay, yeah. So would you advise leaving in the 018 microwire during exchange to avoid losing access? For neonates, babies under 5 kilos, it's difficult to do two, like a safety wire type thing. For older patients, especially if you're going to use like an AccuStick set, I always sort of do that, especially if I'm doing a PCNU, because having that safety wire, I mean, it gives you peace of mind. You clamp it to the drape, and then when you're messing around using guide catheters and stuff to get on, if you accidentally fall out of the bladder, you're not, or sorry, out of the kidney, that you're not gonna, have to keep getting access or whatever. So I routinely use a safety wire when I'm doing GU work, especially in the older kids. Would you advise record technique in adults with maybe trocar technique? Is that what you're saying in adults with severe hydronephrosis? You can do trocar technique in adults with severe hydronephrosis. My answer is sort of yes, you can do it, but Seldinger technique is so safe and it's so easy, and it takes maybe 3 minutes more than trocar technique. So I tend to not do trocar technique unless I have to or have a reason to, because I just feel so strongly about good Seldinger technique and ultrasound guidance and just, complications. So if you want to do it, if like, let's say you don't have a guide wire or there's a shortage of something and you have to do it, learn how to do it, be good at it and do it safely. But if you have the wire and you have the materials, I would say just stick to Seldinger technique, especially early in your career. I notice most cases of complications I've experienced in. Okay, thank you. Severely. Yeah, I saw there was a question about potassium earlier, which I didn't get a chance to look. What is the maximum potassium you can do a percutaneous nephrostomy in a child with obstructive uropathy?
I mean, I think that's that's an anesthesia kind of safety question. So I think our anesthesiologist will want to get that potassium down as much as possible. I think they're okay with a 5. But it's the reason why the potassium is so high is because of the obstructive uropathy, presumably. And so, doing the typical, to get potassium down. I don't know if you all have the mnemonic here, the C big K, calcium gluconate, beta blocker, Caxolate, all these things to decrease the potassium or move it to an intracellular location before anesthesias.
Yeah, that first case I showed, that trocar technique case, that was from Saturday night.
Yeah.
And that kid came in with a potassium of like 7 almost.
Yes, and then the sodium of like 115.
Yeah. And so we basically, she came into the emergency room. I happened to already be at the hospital. It was like around 7 p.m. And we just basically had to wait until she was safe enough to get it. But we also couldn't leave the hospital because it was, I mean, part of the whole electrolyte imbalance is because of the obstructive uropathy. So we just waited till we did some of the C-big-K stuff with the PICU and the anesthesiologist. And then once she was under the threshold, then we placed the nephrostomy tube.
Awesome. That was great. I think we can wrap up. We're almost at the hour, and I would really encourage both the groups in Tanzania and in Uganda and anyone else who's here and has joined, if they have difficult cases, just quickly share the story, a few lines, send whatever imaging you have, and just put it into our training group or the Peds IR group, and then Jay can answer it, right? The best learning is always done on real life cases, and like once you've seen a few of these and you've managed it, then you really know what to do.
Yeah. I'm very easy to find, and Shuvro is a good friend, so I can pass along cases to him too. And especially if you guys are starting to grow a more of a relationship with urology, like we can continue to have more of these sort of lectures and kind of work through what a good workflow could be, and make sure that we're doing the right thing for our patients.
Yeah, I think it's a good relationship that we have. It's an open communication, so very helpful on both sides. And so this was kind of a bird's eye view and very high altitude view in terms of the urologic conditions. But later on, we can go into kind of more in depth, complicated situations.
Awesome.
Awesome.
Thank you so much.
All right, thank you
guys.
Take care, guys. Bye-bye.